Okay, this is an exam 3 review. I know some people missed class because they had family obligations over the long weekend, but I wanted to make sure that you got started on your review because this is certainly one of the more challenging exams of the semester, not just because of the length, number of chapters. It doesn't really divide well. It's more that there's a lot of terminology to learn. But we've had a couple of weeks already, so we're on our way, but definitely want to make sure we get this ahead of time. So the first thing is that you really have to have a command of the acronyms. I might use them from time to time, and so I just wanted to put these up front. FGA for first generation antipsychotic, SGA for second generation antipsychotic. Sometimes you'll hear first generation as typical antipsychotic and second generation as atypical. CNS for central nervous system, and then a couple of neurotransmitters, acetylcholine, abbreviated with a capital A, capital C, little h, for generally the parasympathetic system, but there's exceptions. And then norepinephrine, generally with the sympathetic system. Again, there's some exceptions to that, but NE for the norepinephrine. TCA for tricyclic antidepressant, and MAOI, taking the M from mono, the A from amine, O from oxidase, and I from inhibitor. GAD for generalized anxiety disorder, OCD for obsessive compulsive disorder, and PTSD for post-traumatic stress syndrome. You may or may not see these, but difficulty maintaining sleep versus difficulty falling asleep. It's just an easier way of describing the two patterns that most people have in terms of difficulty with insomnia. NMS for neuroleptic malignant syndrome. The antidote is dantrolene, something we see with succinylcholine, which we'll talk about. Extrapyramidal symptoms and treatments. We'll talk about treatments in a bit, but knowing acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia in that order, in terms of when you would likely see them. So first thing you want to kind of know is when we're talking about antipsychotics, let me get this up to the top now. What's the difference between a first and second generation antipsychotic? So you can look at Memorizing Pharmacology, pages 97 to 99, to check those out. But the big difference, the first generation generally associated with EPS, though there is a little bit of a difference between chlorpromazine, which is low potency, and haloperidol, which is high potency. The high potency more likely to cause EPS, the low potency a little bit more on the sedation side. And then the second generation antipsychotic, these are likely to cause weight gain, hyperlipidemia, and diabetes mellitus, and those kinds of issues. Clozapine, olanzapine, risperidone, and quetiapine are 4 of them. And just knowing these representative drugs when you see them. What neurotransmitters are we talking about? Generally, we'll be talking about when we're talking about especially depression, SSRI, so selective serotonin reuptake inhibitor, has to do with serotonin. And sometimes you'll see this as 5-HT2A. The SNRI, so it's not selective norepinephrine reuptake inhibitor, it's serotonin norepinephrine reuptake inhibitor. So serotonin, norepinephrine, and then the tricyclics, it's about the same with serotonin and norepinephrine. It's just named after the shape of the drug instead. And then the MAOIs, we had dopamine. There's some complication to it, but generally norepinephrine, serotonin, dopamine. And then knowing the drugs that fall into those 4 classes. The SSRI, fluoxetine, the SNRI, venlafaxine, the TCA, amitriptyline, and then the MAOI, isocarboxazine. These are all representative. There are definitely others within each of those classes. Knowing what the extrapyramidal symptoms are and what the treatments are, so I kind of alluded to those up top, the acute dystonia, akathisia, Parkinsonism, tardive dyskinesia. We'll talk about that in a little bit. Okay, so let's start with the basics, axonal conduction versus synaptic transmission. When we're thinking axonal conduction, we're thinking local anesthetics, very few drugs, generally end in cane, the benzocaine, lidocaine, things like that. Because of the metabolism and possibility of allergenicity, we see lidocaine as an injectable, and we generally see things like benzocaine that are not injectable. These are the esters versus lidocaine, which is an amide. Synaptic transmission, this is how most drugs affect the next neuron, really, but neurotransmitters, this is most drugs. And you can maintain neurotransmitter by either having less destruction of it, so we stop the enzymatic degradation of a neurotransmitter by acetylcholinesterase inhibitor or by monoamine oxidase inhibitor, or we have the reuptake, like the selective serotonin reuptake inhibitor, those mechanisms. Sympathetic versus parasympathetic, just a quick reminder, parasympathetic is that rest and digest, the resting meaning we're going to slow the heart rate, increase gastric secretion, probably empty the bladder, empty the bowel. Sympathetic is that fight or flight, or I don't know why I put fight of flight. In terms of cardio, we're going to prepare for this fight or flight by increasing the heart rate and that cardiac output, getting that oxygenation. Body temperature, we're going to have blood flow to the skin and sweat glands. We're going to activate alpha-1, beta-1, and beta-2. So with alpha-1, we increase heart rate and blood pressure by vasoconstricting. Beta-1, we increase heart rate and increase the cardiac force of contraction. And then to get more air, to get more oxygen, we activate beta-2, bronchodilating, also causing glycogenolysis, to provide more glucose, which of course is bad for diabetics. So always want to be careful with things like albuterol and so forth, that are those beta-2 activators. Okay. Anticholinergic versus cholinergic. This is the same as antimuscarinic versus muscarinic. Those are synonyms. The muscarine mushroom was the first thing that scientists discovered, but then they preferred to use the neurotransmitter acetylcholine. But unfortunately, in many textbooks, they just go back and forth, and anticholinergic means antimuscarinic, and cholinergic means muscarinic. So side effects, we want to keep dry in mind, and I like the acronym ABDUCT, ABDUCT. So anhidrosis, meaning lack of sweating, blurry vision secondary to dry eyes, the D for dry mouth or xerostomia, the U for urinary retention, C for constipation, you pull water out of the bowel, T for tachycardia, increase in heart rate, and then the cholinergic side effects, sweating, which is opposite of anhidrosis, lacrimation or tearing, which is the opposite of dry eyes, salivation, which is the opposite of dry mouth or xerostomia, urinary incontinence, which is the opposite of urinary retention, diarrhea, which is opposite of constipation, and bradycardia, the opposite of tachycardia. I've heard the acronym can't spit, can't whatever, but I think it's easier if you have these 6 opposing the other 6, understanding maybe more generally how these go opposite each other. And it doesn't mean that we can't use an anticholinergic to help somebody who has trouble with urinary incontinence, or a cholinergic to help somebody struggling with urinary retention. So sometimes we use these side effects as therapeutic effects. Acetylcholinesterase, just understand that this enzyme will break down acetylcholine, so to keep acetylcholine around, we'll just block it. We'll see 3 receptors, nicotinic N, nicotinic M, and so neuro, muscle, and then the muscarinic is what we really focus on, which also means cholinergic, as I mentioned before. What's its effect on acetylcholine? Well, it'll break it up into acetate and choline. So if we want to have more acetylcholine, we would need to block it. So when we have acetylcholinesterase, what happens to the acetylcholine? Well, we have less around it. And then what do we want to do if we want more acetylcholine to treat certain conditions? Well, we block the acetylcholinesterase. Epinephrine, well known for its use in emergency issues. So the receptors, fight or flight, and anaphylaxis treatment. So the big thing is that it suppresses that glottal edema that you might see with somebody that's having a severe allergic reaction. But alpha-1 receptor is vasoconstrictive, so we increase blood pressure, blood flow to the heart. Beta-1 increase the heart rate, more blood flow and oxygenation. Beta-2, we bronchodilate, creating more oxygen, and then the glycogenolysis, more glucose for energy. The blood-brain barrier. So what's it do? Well, it's supposed to prevent toxic substances from getting into the brain. Is it good or bad? It depends. Good, it protects the brain from toxins. That's why it's supposed to be there. But bad in that there are many drugs that we could really solve a lot of conditions if we didn't have the blood-brain barrier. And it unfortunately protects the brain from drugs that might otherwise help in those therapeutic conditions. What's the difference between infants and adults? You're really talking about development. So the blood-brain barrier is really not well developed in infants. And so the infants are going to be much more sensitive to central nervous system medications. Just a review of agonists versus antagonists, though we've seen blockers and activators before. For example, beta-2 activator like albuterol would be an agonist. An H2 blocker blocks stomach acid would be an antagonist. And we've seen that over and over, but maybe not called it these things. So alpha-1 agonism, we're going to look at the effect, the therapeutic use, the adverse effect, and we'll see this a couple of times. I'm not going to belabor that, but that's what the slashes are for. And this is in Memorizing Pharmacology 112 to 116 if you want to review. So alpha-1, the effect is vasoconstriction, and our goal and number of things that we can do is we can stop blood flow with hemostasis or stop bleeding. But some of the adverse effects we might see is necrosis, because we've stopped blood flow. If we stop blood flow too much, then the tissue will die. We can vasoconstrict to treat hypotension, but we might unfortunately cause hypertension if we vasoconstrict too much again. And then another effect is bladder contraction. Not really much of a reason therapeutically to do that. Some examples of the alpha-1 agonism would be epinephrine or phenylephrine. Alpha-1 antagonism. So the effect is vasodilation, and one of the therapeutic effects of to decrease blood pressure. But unfortunately, that first dose syncope, first dose fainting, first time patient takes it, we have to worry about orthostatic hypotension. So we want to make sure that they take it at bedtime. The other issue, which seems a little counterintuitive, is that if you vasodilate, you're going to get tachycardia. Why is that? Well, the body is saying, oh my gosh, blood pressure is going down, alert, alert. So let's do something to counter that. And increasing heart rate is a good way to do that. Number 2, blocking bladder contraction. So this can help with something like benign prostatic hyperplasia, but it might also cause some issues with sexual dysfunction. So the prostatic capsule, the bladder neck is affected. It inhibits ejaculation in terms of the sexual dysfunction. A lot of times this is the issue where patients won't take it. Some of the examples, doxazosin, which is Cardura, and you can see the CARD from cardiac in there, and that's really letting you know that this one will affect the blood vessels, where alfuzosin, which is uroxetrol, and tamsulosin, which is Flomax, this one really weak vasodilators, which means that they're doing a good job working towards BPH, and you can see the euro as in urine, and then control, and then the flow max, maximum flow, trying to help the patient who might be having issues with going to the bathroom and so forth. This is in Neuro because we're talking about the receptor, but in Memorizing Pharmacology, I put doxazosin in Chapter 6 because of its effect as antihypertensive, and I put alfuzosin and tamsulosin in Chapter 7 because these both affect the prostatic capsule, and really it's more about BPH. Beta-1 versus beta-2, so we've gone through alpha-1. So the same thing, we've got a review Memorizing Pharmacology 112 to 116. Might be good just to get the background. But beta-1, the target organ is the heart, and will increase heart rate, and that would help with something like heart failure. If you don't increase it too much, and we could get tachycardia as an adverse effect. Increase the force of contraction. So again, with something like hypotension or shock, this might be a good idea. And we might actually get some issues like angina with something like this. because we're asking too much. We're asking the body to pull too much oxygen. Increase the speed through the AV node for something like AV block. I couldn't really find an adverse effect with this. If you've got AV block, obviously this is a good thing. Beta 2, target organ is the lungs. So the common way to remember this is you've got one heart, so beta 1, and 2 lungs, beta 2. Bronchial dilation, this is to maybe help with asthma or COPD, something like that. But one of the adverse effects is hyperglycemia, and this hyperglycemia comes from glycogenolysis, where we've got more glucose being cleaved off of the glycogen because of loss of selectivity at the higher doses. So while generally we're going to see patients' airway improving, if you give really high doses, somebody keeps using albuterol all day, doesn't use the prophylactic forms, then sometimes this will affect the heart. You get very tachycardic. And then again, as I mentioned, glycogenolysis causing hyperglycemia. No reason that we would want to do that on purpose. Some examples, so maybe epinephrine or isoproterenol as the beta agonists. Looking at beta 1 and beta 2 antagonists, so the effect, therapeutic, and adverse. Again, that same memorizing pharmacology, 112 to 116. Beta 1, so if you're going to block beta 1, it's just going to be the opposite, where you decrease heart rate. You can improve something like hypertension, although I understand it's really not the drug of choice now. But you can cause bradycardia if you lower the heart rate too much. You can decrease the force of contraction, which may be good if you have angina, you put less work on the heart. But this may precipitate heart failure, so we want to be careful. And then decrease speed through the AV node. Watch out for dysrhythmias, and then AV block as an adverse effect. Beta 2, so we don't really want to do this on purpose, but because of the lack of selectivity with some of the beta blockers, we might see bronchial constriction, so we want to avoid them in asthmatics. That first generation propranolol would be something that we want to be careful with. Carvedilol is third generation, and that's also non-selective, and I'll explain that in a second. And then you would also see blocking glycogenolysis and then hypoglycemia as the adverse effect. So the example, we want to put them into non-selective and selective. First generation is propranolol. It's non-selective in that it doesn't select for beta 1 or beta 2. It actually affects both beta 1 and beta 2 receptors. So it will decrease heart rate, but it will also cause some issues with bronchoconstrictions and asthmatics. Third generation carvedilol, this is also non-selective, but the reason it's third generation is it not only affects the heart, but that DIL stands for vasodilator, and that vasodilatory effect counters what you would normally have when you decrease heart rate. Normally the body would vasoconstrict and stop the good effects that you're trying to do, which is help a hypertensive, and instead it'll vasodilate at the same time it lowers heart rate, hopefully decreasing blood pressure better than others. And then selective, second generation atenolol, metoprolol, all ending in OL for beta blocker. Catecholamine versus non-catecholamine. So a catecholamine example would be something like epinephrine, and there's three real things we want to know about it. First, we can't use it orally, and you just think, well, an EpiPen isn't something it's not a tablet, obviously, it's an injectable. It can't cross the blood-brain barrier, and then it's very short half-life because you have this metabolism by monoamine oxidase and then catecholomethyltransferase. The names of the enzymes are not as important as knowing that it has this very short half-life. And if you think about epinephrine, you don't think of it as something that lasts 4 to 6 to 12 hours or anything like that, just a couple minutes. Whereas you have a non-catecholamine, so the example would be phenylephrine, and you can use something like this orally, whether it's liquid or spray or something like that. It can cross the blood-brain barrier, and it has a much longer half-life because there's reduced metabolism by this monoamine oxidase and catecholomethyltransferase. Okay. Epinephrine, just want to make sure we know the difference between the concentrations. If you're using it as an adjunct to a local anesthetic to prevent bleeding or to reduce the dosage that you have to use of lidocaine or something, for example, we're talking about 1 to 100,000. So we can reduce the dose of anesthetic, we can decrease the toxicity of the anesthetic. If we're using it for anaphylaxis, we're talking about an order of magnitude different, where it's a 1 to 1,000 concentration for some that's an adult greater than 30 kilos, which is about 66 pounds. And if you're using the children's one, you're talking about a 1 to 2,000 concentration, where maybe the patient's somewhere between 33 and 66 pounds or 15 to 30 kilos. But the takeaway here is that the concentration for the adjunct to local anesthetic versus anaphylaxis is much, much different. Okay. Local anesthetic. So epinephrine allows for a reduced dose of lidocaine because it kind of keeps the blood around that has the medicine. So hopefully we have decreased toxicity, and that's a misspelling. Oops. Okay. With something like epinephrine, we might. Well, this doesn't make sense. So first dose syncope and fainting, I kind of mixed two things. So a local anesthetic like epinephrine is going to cause vasoconstriction. It's an alpha agonist. But if you have an alpha antagonist, and I mentioned this before, we're going to have something like first dose syncope or fainting. So let's just put, just for clarity, this is an alpha 1, okay, antagonist, usually for BP. Okay, so what happens? We get vasodilation. The body would normally just increase heart rate, but the rate at which it can make the heart tachycardic can't keep up, and then the patient just drops. So the solution is to give the first dose at bedtime. Okay. Migraines, so prophylactic versus abortive. Migraine prophylaxis, we saw this in musculoskeletal section, which is chapter 2. But 3 drugs that you can use are the beta blockers. Again, those that end in OLOL. Something like amitriptyline, which is a tricyclic antidepressant. And then some of the anti-epileptics are also good for migraine prophylaxis. So preventing the migraine in the first place. We're not sure necessarily how some of these mechanisms work, but again, it's effective. Abortive means that we have a migraine and we want to stop the migraine. So something like Excedrin migraine, we want to know why those 3 components are in there. The ASA is the aspirin for inflammation and pain. The APAP is the Acetaminophen or brand Tylenol, which is for just the pain. And then the caffeine is a vasoconstrictor, and that's supposed to, if you want to think of migraine as a dilating blood vessel, and if you constrict it, then you reduce the amount of space that it takes, and the idea is that it would help with the pain. But you can also use ibuprofen or naproxen or something like that for a mild headache, really. That migraine may be the wrong term here. But when you do have the migraines, you have something like elatriptan, and these are the triptans, or... let's underline the triptan stem, and the sumatriptan, which is Imitrex. Then we're talking about using a little bit, I don't want to say stronger medicine, but more specific medicine that's going to help with those vasoconstrictive effects, and that's going to hopefully reduce the pain. But again, if you have that type of thing, then you really want to be careful with any patient that's having issues with, I would say, cardiac issues, hypertensive issues, especially brain issues if they're having vascular issues. Opioid analgesics, so hydrocodone, acetaminophen, Vicodin, these we really reserve if the other methods are failing because of their addictive potential. Now this Vicodin is C2 by the DEA, so we really want to be careful about using opioids. Alpha-2, so the alpha-2 agonist clonidine, just to know that it's useful in ADHD with hypertension, and if you take it away too quickly, you might get a rebound hypertensive effect, which is a concern. Anticholinergics, so this is overactive bladder. I don't know if I mentioned this. Okay, taking the O from over, and then A from active, and then B for bladder. If something is M3 selective, so the M3 receptor is something that is in the bladder, we can expect less dry mouth. So something like oxybutynin, brand Ditropan XL, or oxybutynin, which is Oxytrol for women. It's a transdermal patch available over the counter. A non-selective one, we would expect more dry mouth, so something like tolterodine. Detrusor control is how I remember Detrol, but Detrol or Detrol LA. The takeaway here is that anticholinergics cause dry, opposite of wet, and we use what is normally a side effect as a therapeutic effect. Atropine poisoning and an antidote. So knowing that atropine is an anticholinergic, okay, and anticholinergic needs what if you have toxicity? So if you have toxicity from something that is an anticholinergic, something that is blocking acetylcholine, then we need more acetylcholine, and so we want something cholinergic. So if something that is cholinergic is going to give us more or less acetylcholine. It's going to give us more. And then can we give acetylcholine directly? Generally, no. So that we're going to have to do something a little bit different. And in this case, what we do is we block acetylcholinesterase with an acetylcholinesterase inhibitor to keep the acetylcholine around, keep it from getting broken down. And if you have something like physostigmine, it doesn't have a positive charge, and it can go through the CNS. Neostigmine versus physostigmine. So if we're talking about poisoning by anticholinergic or muscarinic blockers, neostigmine doesn't readily cross the blood-brain barrier. It's again getting a little into organic chemistry, but it's a quaternary ammonium ion, where physostigmine readily crosses the blood-brain barrier. It's tertiary ammonium. And if you think about ammonium versus ammonia, if your body can change ammonia to ammonium, then it becomes positive and can go into the urine and it's easily excreted. But if it can't, then it becomes toxic to the patient. But just as an understanding of quaternary versus tertiary, you're adding a hydrogen. Neostigmine, so it's something we use for myasthenia gravis. We adjust the dose by seeing the patient's ability to raise their eyelids or swallow, and really just seeing how the patient's doing with the medication. Succinylcholine, I understand that we use some other drugs for this. No, that's not right. Succinylcholine. But it's a good drug in terms of knowing what we need to, in terms of intubating a patient. So the issue is malignant hyperthermia, extremely high temperature. I've seen in certain texts as much as 106, 109. So first thing, of course, to discontinue the drug itself, the succinylcholine. Cool the patient. Normally you would think ice packs, but really iced saline would be ideal. So we cool the core, but ice packs if that's all you've got. And then dantrolene as an antidote. We'll talk about that a little bit later. Okay. This is talking a little bit about schizophrenia. So FGA versus SGA is first generation antipsychotic versus second generation antipsychotic. In general, it takes months to improve. So need to be somewhat patient with these medications. The first generation antipsychotic, again, we call that the typical. We have this EPS or extrapyramidal symptoms because of a strong dopamine blockade, D2. And the potency just allows us to know that there are certain characteristics. So it takes about 100 milligrams of chlorpromazine, brand Thorazine, to do the same thing as 2 milligrams of haloperidol, brand Haldol. Now they do the same thing, they provide the same effects for the patient, but it's the side effects that we're making the decision on which medication to use. So chlorpromazine would be high sedation, moderate EPS or extrapyramidal symptoms, where we had a very low sedation with haloperidol, but very high chance of extrapyramidal symptoms. Second generation antipsychotics, so these are the atypicals. We have less EPS because of a moderate dopamine blockade, but we have severe metabolic effects, diabetes, dyslipidemia, and weight gain. The examples, I shouldn't have put them in. Yeah, okay, so these are in alphabetical order, but aripiprazole, and be careful of that piprazole stem, just because it looks a lot like that prazole from the proton pump inhibitor. This is something the World Health Organization certainly doesn't approve of, but kind of slipped through somehow. But aripiprazole is Abilify, olanzapine, quetiapine, and risperidone. All 4 of these are second-generation antipsychotics. Positive and negative symptoms. So the positive symptoms, and this doesn't mean positive like good thing. It's positive like hallucinations. There's something new, there's something there where there wasn't. And then the negative symptoms, something poor, something has been taken away. So there's no evidence that I've seen that SGAs are better than FGAs. It's really about side effects in terms of helping with these symptoms, though before there was some evidence, now maybe not. But we want to know what those side effects are if we're going to be making decisions based on those side effects and what we can do if we have them. So if we have acute dystonia, we can use an anticholinergic like diphenhydramine. There's some other ones you can use like benzodiazepine. Parkinsonism. Now this isn't Parkinson's disease. This is Parkinsonism. We can use anticholinergic, diphenhydramine, something like that. We would probably have to switch to an SGA because it has less EPS, maybe haloperidol to risperidone, because Parkinsonism doesn't always respond really well to these treatments. Akathisia. So akathisia is an inability to sit still. So anticholinergic or beta blocker or benzodiazepine. And we would switch to low potency because it would have that less EPS here. So we could stay within the first generation, but try to reduce the EPS. And then tardive dyskinesia, we'd want to DC all of the anticholinergics. We might give benzodiazepines, we might decrease the dosage, or we might switch to a second generation antipsychotic. Depot preparations. Depot preparations are those that, and let me put the piprazole again here just to remind you. Depot preparations are long-acting preparations, those that it's very difficult to give patients that have psych issues medication, and it would be nice if we could just give it every couple of weeks instead of every day. So with aripiprazole, haloperidol, we could give every 4 weeks an IM injection, olanzapine every 2 or 4 weeks, risperidone every 2 weeks. The takeaway, though, is that a depot preparation is a preparation that you can use to reduce the number of times a patient has to get the medication to improve the amount of time that they have the medication. Okay. Depression, suicide symptoms, we want to hospitalize that patient if they're showing severe depression or suicide, or talking about it. So depression, what's the monoamine deficiency hypothesis? We're still using this, although there's some back and forth on it. Monoamines are norepinephrine, NE, serotonin, and then we'll talk a little bit about why it makes sense, what we're trying to do. So the SSRIs are the selective serotonin reuptake inhibitors. They're named after the neurotransmitter serotonin, and these are citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. We want to be careful with SSRI withdrawal that we don't withdraw too quickly. SNRI, so serotonin norepinephrine reuptake inhibitor, also named after neurotransmitters, serotonin and norepinephrine. And these examples are venlafaxine, desvenlafaxine, and duloxetine. Careful with that oxetine ending. Anything that ends in oxetine is supposed to be a fluoxetine-like medication, but this becomes confusing that this is an SNRI, and then something like fluoxetine and paroxetine are both SSRIs. So it gets a little bit confusing there, but just want to keep those in mind. Okay. Tricyclic antidepressants named after the shape. So amitriptyline, Elavil, it's meant to elevate your mood. It's very dangerous in overdose, why the SSRIs were such a boon when they came in. So it is potentially lethal, and it only takes about 8 times the therapeutic dose. So that's just saying that patient takes 8 times or over a week's supply all at once, and that could cause death, especially concerning in patients that are suicidal and very depressed. Within the elderly, we would want to be careful to divide the doses because there are some cardiotoxic effects as well. Okay. The MAOIs, so again, the 5-HT2A, I could put 2A here really, but and then subscript, I may not be able to get that off of this font. Yeah. Oh, here we go. Okay, completely unnecessary, but all right. So 5-HT2A and norepinephrine. It's a monoamine oxidase inhibitor. So when we're talking about MAOA, we're talking about norepinephrine serotonin, we're talking about MAOB, we're talking about dopamine. And it blocks the enzyme that degrades these neurotransmitters. And the example is isocarboxazid brand Marplan. The tyramine, though, is the big concern if we have foods like cheese or Chianti and chocolate. And every time I say this, I'm like, gosh, that really sounds good. But we want to be careful because it's like adding more epinephrine, which is like epinephrine, in fight or flight, and increases hypertension. So we can have hypertensive crisis if we have monoamine oxidase inhibitors and tyramine together. Okay. Bipolar disorder means we have, versus unipolar, which means that, they're just depressed or just manic. We have mania and depressive episodes. We use mood stabilizers, and I put Y seizure medicines just really to get in your head that if you think of chaotic electrical activity and that a seizure is chaotic electrical activity, then something that stabilizes that activity might be an antiepileptic or something like that. Lithium or lithobid is really what we want for something like a pure manic episode, a euphoric mania. Whereas carbamazepine and divalproex, both the antiepileptics, the Tegretol and Depakote, generally for the other types of episodes. Compliance is a real issue because if somebody's manic, they're very happy and they see no need for medications. Okay. Antidepressants, we want to be especially careful of hypomania or mania risk because if we give an antidepressant to someone who's depressed, we might just throw them into mania. So we want to add a mood stabilizer while we do that. And then lithium toxicity, it's a very narrow therapeutic window. So want to be careful not to be subtherapeutic under 1.5. And want to be careful of going toxic. And the drug interactions really come from sodium. So sodium and lithium are both +1, both on the far left side of the periodic table of elements. And what we want to just kind of intuit or kind of think in our heads is, why would sodium increase if somebody got a diuretic? Well, if you release fluid, then the body's going to try to hold on to sodium, to hold on to fluid, and it's not really going to know the difference between the sodium and the lithium, so it'll hold on to both. Non-steroidal anti-inflammatory drugs have this effect of on renal reabsorption, so also a real concern with sodium. And then anticholinergics, it's going to cause this urinary retention, that dry from the abduct acronym. And if we're holding on to urine and sodium, then we're also holding on to lithium. So where the sodium goeth, the lithium goeth too. Risperidone, which is brand Risperdal, a second-generation antipsychotic. It's often useful in bipolar while we're waiting for the lithium and other levels, medication levels, to get right. So this would be something that we see as an adjunct or something in addition. Okay. Barbiturate versus benzodiazepines. So a good example is phenobarbital versus temazepam. We have phenobarbital as the barbiturate and temazepam as the benzodiazepine, and you see that azepam stem. And then the barb is the actual barbiturate stem. But phenobarbital, temazepam, the big difference is that the benzos are generally safer. And when we're talking about why they're safer, it kind of comes down to here, where with temazepam, and we're talking about GABA now, the gamma aminobutyric acid, there's a ceiling, and that ceiling keeps the respiratory depression from going down as much as a phenobarb would. And if you want to talk about dosages, these barbiturates are still used quite a bit in veterinary medicine. And the difference between treating an epileptic animal and putting an animal down is simply dosage, but they use the exact same drug often. Okay. Anterograde amnesia, so this is difficulty forming memories that are going to happen. So you can't forget something that hasn't happened yet, but what you're doing is having difficulty forming those memories. You might hear about sleep driving, where somebody drove somewhere and has no idea what they did. Or retrograde amnesia, which means you forget things that are in the past. DFA versus DMS, I've seen this once, but these acronyms I don't see too often, but I think it's just useful in terms of what this medication is for. So some people really struggle to get to sleep in the first place. So we want something that has a short half-life like Zaloplan, Brand Sonata. And that means that, well, the medicine's going to work for a little bit, and that's it. It helps you go to sleep. But if you have difficulty maintaining sleep, you want something with a bit more of a half-life. And Temazepam, which is brand Restoril, you can see Rest in the brand name, and Acetaminophen, which is pro-som, so pro-somne. Somne is to sleep in Latin, so it just means to sleep or helping someone sleep. Those are intermediate acting. Or you've got something like Zolpidem, which has two different forms. The original form, the Ambien, was just for people having difficulty falling asleep, where the Ambien CR, controlled release, helps people that have difficulty falling asleep and difficulty maintaining sleep. Again, knowing which is the issue is really the key to helping these insomnics. Okay? Benzos and uses. Besides general anxiety disorder, we see it in panic disorder, obsessive compulsive disorder, social anxiety disorder, PTSD as well. It's generally second line because SSRIs are safer. They're not addicting like the benzos are. And the benzos are C4. I'm not trying to minimize it, but SSRIs are a little bit better. But when you want something like, and I'm skipping buspirone for a second, stage fright, where you're only going to maybe have a couple presentations, it doesn't make sense to put someone on an SSRI for a couple of months to help with this anxiety. You would just maybe give them a couple of alprazolam, which would help reduce those anxiety feelings. Or you can give something like propranolol, which would reduce the heart rate. Of course, we want to be careful with an asthmatic with this non-selective beta blocker. But two different ways to deal with that kind of anxiety. Buspirone, it's something that's not controlled. It takes a week to develop, but an alternative to benzodiazepines. It's non-controlled and non-addicting. Okay. Not sure why I separated these two. This really should just come down here. Okay. And I can just do this. So it takes a week to develop. Just get rid of that. Okay. All right. And then some questions I'll answer in a follow-up video talking about Parkinson's, Alzheimer's, and antiepileptics. I'm going almost 45 minutes already, so I wanted to kind of cut this off. But what are acetylcholine and dopamine's roles in Parkinson's disease? What are 5 ways to get dopamine to the brain? We have to be very clever because of the blood-brain barrier. How do the adverse effects match the neurotransmitter? So what do we expect with adverse effects? Why do we use carbidopa instead of dopamine itself? And then, how do we use levodopa is what I mean. Levodopa and not dopamine itself. And then how does carbidopa help levodopa increase the amounts that reach the brain? Okay. 5 questions for Alzheimer's. So what are the 2 hallmarks of Alzheimer's? There are 2 things. What are the new drugs focusing on the treatment? So there's some internet research. It's just recently, you want to say a couple of weeks ago on NPR, and a cancer drug that seems promising for Alzheimer's. What do the cholinesterase inhibitors focus on for treatment? Why does it make sense to use a cholinesterase inhibitor? And then, which is better, that new drug that's coming out, the cancer drug, and that approach, or the current drugs that we have? And this is just kind of an opinion, but it really helps to, kind of solidify the mechanisms of action. And then the antiepileptics. What's the difference between the traditional and newer antiepileptic drugs? So I've got the traditional newer agents in memorizing pharmacology. So the dilantins and carbamazepines for the traditional agents. Pregabalin, gabapentin as two of the newer agents. What makes phenytoin, which is a great drug, less safe than the other antiepileptics? What are the signs and symptoms of that phenytoin toxicity? And then what do we do if we have a patient who is pregnant but also epileptic? Okay. So that's 45 minutes. It's about how long I wanted to go. So hopefully this is helpful.